Provider's Classroom. I'm Janessa Jacobs, and this is the respiratory system. So, if we look at the respiratory system, there's an upper respiratory system and a lower respiratory system. The upper respiratory system starts with the nose and leads into the nasal cavity, which then leads back into the pharynx. The pharynx brings air into this structure called the larynx. The larynx leads into the trachea, which leads into the bronchial tree. So we've got our nose, our nasal cavity, our pharynx, and all that stuff is in the head. This is the upper respiratory tract. And then we get to our larynx, which then leads to our trachea, which then leads to our right and left main bronchi. One is a bronchus. So I've got a right and left main bronchus. We'll look more at the bronchial tree in a little bit. But these are the structures. From here, we're going to branch into what's called the bronchial tree, and that gets smaller and smaller and smaller until we get down to our teeny tiny little air sacs called alveoli. And if you remember, alveoli are made of simple squamous epithelial tissue, and that provides the thinnest possible barrier in the body across which our respiratory gases can quickly diffuse. So all of these structures from the larynx down are part of your lower respiratory system or your lower respiratory tract. And all of the structures that are bringing air into the alveoli where gas exchange is actually going to occur are considered structures that are part of what's called the conducting zone. So these are all of our conducting zone structures, from the nose through the nasal cavity, the pharynx, the larynx, the trachea, all the way through our bronchial tree until we get down to these very teeny tiny little things called respiratory bronchioles. We've got respiratory bronchioles that can do a little bit of gas exchange. But really, where we do our gas exchange are in these structures called alveoli. So our respiratory bronchioles and alveoli are the places where we can do respiration. So these are the only structures that are part of our respiratory zone. The respiratory system and the cardiovascular system work together to serve your tissues with oxygen. So there are actually 4 processes involved in respiration, 2 that are handled by the respiratory system and 2 that are handled by the circulatory system. So if we think about respiration, it's actually a 4-part process. Most people think of respiration as just breathing. That's only one part of respiration. It's the first part, called pulmonary ventilation. So our first process of respiration that's handled by the respiratory system is pulmonary ventilation. So we'll go through that in a little bit. Then at the level of the alveoli, we have what's called external respiration or alveolar gas exchange. So external respiration is also handled by the respiratory system. And it's also sometimes known as alveolar gas exchange. Now, the circulatory system is going to help get oxygen to the tissues and CO2 from the tissues back out to the lungs by transporting it in blood. So gas transport is the third process in respiration, and it's handled by the circulatory system. And then when we get to the level of the tissues and we exchange oxygen and CO2 at the tissue level, we call that internal respiration or tissue gas exchange or systemic gas exchange. And this is happening happening at the level of the capillaries, which is why it's a function of the circulatory system. So again, respiration is a four-part process. Two parts handled by the respiratory system, pulmonary ventilation, and external respiration, or alveolar gas exchange. And two processes handled by the circulatory system, gas transport, which is the transport of our respiratory gases in the blood, and internal respiration, which is tissue gas exchange. So we are going to look at the structures of the respiratory system in greater detail and talk about the way that these structures lead to their functions. So as we move through, we should think about the epithelial tissue that we find lining the mucosa of each organ, and we should also think about specializations in each organ that give rise to the specific function of each structure we're going to talk about. So we'll start by talking about the nose. The nose is going to be the, well, we all know what a nose is. Grab your nose, feel it. So your nostrils are called external nares. And they lead into your nose. If we think about what forms our nose, the bridge of your nose is formed by nasal bones. So those are nasal bones. And then you've got kind of got the frontal process of the maxilla that kind of gives rise to this outer part of your nose. And then down here in the front, these are all of our nasal cartilages, and that's all hyaline cartilage. So our nose has our nasal bones, kind of up top. And then all of these cartilages that make up our delightful noses. On the sides, this would be a horrible nose. Sorry if you have a nose that looks like that. So this is hyaline cartilage. And if you remember, cartilage is always a target for insulin-like growth factors, so this is why noses continue to grow throughout life. So, all right, that's the nose. What does it do? It brings in our air. So to where? The nasal cavity. So if we look in the nasal cavity, we actually see that it's got our superior, middle, and inferior nasal concha. So they're going to be important, and we'll talk about the functions of those in just a minute. So we've got a superior, a middle, and an inferior nasal concha. Or their nasal whatever. So if we look in here, this tissue is pseudostratified ciliated columnar epithelial tissue. And if you recall, cilia beat mucus along cell surfaces, so these pseudostratified cells are going to propel mucus from your nasal cavity back to your pharynx. So your pharynx is a muscular funnel that conducts air to your larynx and food to your esophagus. So if we look in the nasal cavity, we've got this pseudostratified ciliated columnar epithelium that can grab the mucus, propel the mucus is there, but when you breathe in, these nasal concha are going to create turbulence in the air that whacks the mucus into the mucous membrane, traps any debris, and then you beat that mucus back to your pharynx where you can swallow it. Because if you swallow it, then any dust, debris, potential pathogens that may have been in that mucus can be digested by the hydrochloric acid in your stomach. So that's pretty cool. So our nasal cavity then is, if we looked at a function of these, we could say it propels mucus to the pharynx. And so if we zoom in here, what are the functions of the nasal mucosa and the concha? So the mucosa is pretty cool. It actually acts as part of like the innate immune system. This gives you some innate immunity because it traps debris and any potential inspired pathogens. I guess I should say antigens. So the nasal mucosa is really helping with that. The nasal concha are doing a couple things. The superior nasal concha here actually has a special unique function among the three nasal concha. If you recall, the olfactory epithelium is found at the top of your superior nasal concha. So when you're trying to smell something, you sniff it all the way up to your superior nasal concha, where it can then interact with your olfactory epithelium that's going then up through your ethmoid bone. So for our superior nasal concha, we're going to say it has a specialized function in assisting with olfaction because it contains the olfactory epithelium. So this is important for olfaction. And again, that's because it contains our olfactory epithelial cells. Or the olfactory epithelium, the special sense organ for the sense of smell or olfaction. Okay, then all of the nasal concha, their job is to create turbulence. So they make the air turbulent. So they make the air turbulent. Why is that important? Well, when it's turbulent, then we can whack it into that mucous membrane, and that's going to do a couple things. It's going to help with this innate immunity function, but it's also going to help to humidify and warm the air. So we'll make our air turbulent, and we're going to humidify and warm the air. So those are the important functions of the nasal mucosa and nasal concha. Be able to identify these on models and name their functions. Okay, so from the nasal cavity, air is going to be conducted into the pharynx. And the pharynx has functions for two systems. The digestive system, where it conducts food and materials from the oral cavity into the esophagus, and then it functions in the respiratory system, where it conducts air from the nasal cavity to the larynx. So the pharynx has three parts. It's got the nasopharynx that's right behind the nasal cavity, that's going to lead into the oropharynx that's right behind the oral cavity, and then the laryngopharynx that is going to lead right into the larynx. So nasopharynx we have first. And if we look at the cells in the nasopharynx, we can see that these are also our pseudostratified ciliated columnar epithelial cells. And that's because our nasopharynx is hopefully just monitoring or just conducting material from your nasal cavity back. So we had our nasal cavity here. Now, sometimes you might get a little milk up your nose, and in that case, then some milk's going to go up your nasal cavity. But that's not the idea. The idea is that it should just be conducting air. So we find our pseudostratified ciliated columnar epithelial tissue there. The next two regions conduct air and food. So we find a different tissue type there. What tissue type might we find in an area that's going to conduct food? Food is abrasive. Ding, 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 you got it. Stratified squamous epithelial tissue. And since this is a mucous membrane, it needs to be non-keratinized so it can be wet. So in our oropharynx and our laryngopharynx, we find stratified, non-keratinized, stratified, squamous epithelial tissue. And why do we want that there? Because it resists abrasion. That's right. So as the food that you swallow is conducted down your oropharynx and laryngopharynx, it can rub on that area, but then it's going to be conducted back to the esophagus if we're talking about food. But we're not. We're talking about the respiratory system. So the pharynx is going to conduct air to your larynx. Lay people call your larynx your voice box. So your larynx has several cartilages that are going to give it structure and help to support and protect the vocal folds, which are the source of your ability to produce sound. So as you breathe past your larynx, you can vibrate your vocal folds, which are your vocal cords, or lay people call them vocal cords, your vocal folds, and so you vibrate and produce sound. There are other folds in there, vestibular folds, that only cats and monks use. So some monks, not all monks. Cats use them to purr, and some monks use them in like deep meditation. So we'll look at a model in lab, and I'll show you your vocal folds and your vestibular folds. We'll also look at the different cartilages that are present in the larynx. But think about this. Just because you can produce sound, does that mean you can speak? The answer is no. Speech requires your nervous system, your muscular system. It requires a lot of training for you to learn how to control the muscles that are involved in producing words. So you've got to be able to learn how to move your tongue and your lips and your cheeks and all of that to produce all of the words you want. So just because you can make sound doesn't mean you can necessarily use it in a productive way. And just because you can speak doesn't also necessarily mean you are doing it in a productive way. Let's get back to being productive and learn more about this larynx. So, what do we want to say about it? We don't really have to learn more about it, but we could say that the larynx is the voice box, and its function is to, we'll say it vibrates air to produce sound. And then we'll talk more about the larynx when we're looking at a model of the larynx in lab. It's just not very easy to do without figures, so we'll just leave it. In the interest of not violating any copyrights, I'm not using figures. We're getting to use my hand-drawn pictures, and I know you all love that. Okay, so epithelium of the larynx. Silly me. So the superior part of the larynx has our stratified squamous epithelial tissue, and the inferior part of the larynx is back to pseudostratified ciliated columnar epithelial tissue. So for epithelium of the larynx, the superior aspect, we find a little bit of our non-keratinized, stratified squamous epithelial tissue. And as we move more inferiorly, and it's really just a very little part. So as we move inferior, we'll see that we move back to the pseudostratified ciliated columnar epithelial tissue. So now, this tissue and all of the ciliated cells below here are going to form what's called the mucus escalator. So what the mucus escalator does is it beats all of the mucus in your lower respiratory tract up to your pharynx. Why? So we can swallow it, because then it goes down our esophagus and gets to our stomach where there's hydrochloric acid and helps with all that innate immunity stuff. So if you inhale something or inspire something that is able to make it past your nasal cavity and make it all the way into your larynx or any of the lower structures, then this mucus escalator propels all that mucus back up to the pharynx, so we can have the same kind of innate protective effect that we had from the nasal cavity. Okay. Voice production, we talked about it. Your vocal folds vibrate and we produce sound. From our larynx, air is conducted into the trachea, and the trachea is going to lead into our bronchial tree. So let's just say that's our bronchial tree there. In the trachea, we have all of these C-shaped cartilages called tracheal cartilages. Anybody remember what kind of cartilage the tracheal cartilages are? It's hyaline cartilage. Most abundant cartilage in the body. So this is hyaline cartilage. And the function of our tracheal cartilages is really to keep the trachea open. Gives it structure. So our tracheal cartilages give structure. Now, behind our trachea is our esophagus. And so if we look on the posterior aspect of the trachea, we actually see that there's this little muscle, the trachealis muscle. And we have a trachealis muscle on the back and these C-shaped rings in the front because we don't want a complete ring of cartilage around the trachea. Since the esophagus is passing behind it, we want the trachea to be able to have a little bit of give. So we know, we've all swallowed a piece of steak that maybe we didn't chew quite enough and we felt it like pull its way down our esophagus. Well, if we didn't have that trachealis muscle in the back, as that was happening, you would just like run down these ribs of cartilage. So that doesn't work. So instead we throw a muscle back there, and then your esophagus can push a little bit into your trachea without compromising your ability to breathe at all. Okay, so from the trachea, we move into our bronchial tree. So what is this all about? So if we look from our trachea, we're going to branch into first what are called our main bronchi. So we've got a right main bronchus and a left main bronchus that are then going to divide into lobar bronchi. And in just a moment when we look at the lungs on the whole, we'll see that the lungs are sided. Well, we're gonna see it now. The right lung has 3 lobes, superior, middle, and inferior, and the left lung has 2 lobes, superior and inferior. The left lung also has a cardiac notch to accommodate your heart. So we have differing numbers of each of our types of bronchi then based on that. So if we look, our right main bronchus is then going to branch into our next type, which are called lobar bronchi, and in the right lung, we've got a superior, a middle, and an inferior lobe. So we have superior, middle, and inferior lobar bronchi. So all of these, I'm actually gonna, all right, here in green, these are lobar or secondary. So, you know, we like to name things a million ways. So lobar bronchioles are also, lobar bronchi are also known as secondary bronchi. So our main are also known as primary. So primary bronchi are our main bronchi. And then secondary bronchi are our lobar bronchi. And then we're going to move into tertiary, which are segmental. Tertiary bronchi. And there are differing numbers of segments in each lobe, so I'm not going to draw out the entire rest of the bronchial tree. We'll look at that in just a minute, but just be aware of that we will talk about our left main bronchi. But our tertiary bronchi are our segmental. So each lobe of the lung has differing numbers of segments that we'll talk about in just a moment, and those are served by segmental bronchi. I'm not going to draw out. We do have to know the names. You don't need to know the names of all of your lobe segments. We do need to know the names of our lobes. So we will know the names of our lobar bronchi. So on the left lungs, since we have two, we will branch into a superior and inferior lobar bronchus. Superior lobar bronchus, inferior lobar bronchus to serve the two lobes on that side, and then those will branch into the segmental bronchi that serve each lung segment. So our left main is going to branch into our superior lobar and inferior, left inferior lobar bronchi. And on the right side, again, we've got right superior, middle, and inferior lobar bronchi, and on the left side, superior and inferior lobar bronchi that are serving these different lobes of the lungs. Then branching off of our lobar bronchi, we have our last type, the tertiary or segmental bronchi that serve each of the different segments of each lobe. So that's the bronchial tree. And it is, like, well, as we already talked about, part of the conducting zone. So our conducting zone structures are everything all through this bronchial tree, all the way down to these little teeny tiny, what are called bronchioles. So we go from these segmental bronchi to smaller and smaller bronchioles until we get down to these little teeny tiny things called terminal bronchioles. So for our conducting zone structures, that's our nose to our nasal cavity, to our pharynx, to our larynx, to our trachea, to our main bronchi, to our lobar bronchi, to our segmental bronchi, to our smaller and smaller bronchi till we get to these bronchioles that are going to lead into terminal bronchioles. None of these structures has gas exchange occurring. All of these structures are just conducting air into the respiratory zone where we're going to do gas exchange. So everything we've talked about so far is a conducting zone structure. When we get down to these teeny tiny little terminal bronchioles here, then we're going to go into our respiratory zone. If you look in the respiratory zone, we get these little teeny tiny respiratory bronchioles, and this is where we see our alveoli. So primarily gas exchange is occurring at the alveoli. This is the site of gas exchange. As you're moving down the bronchial tree, what's happening is you're going from these C-shaped cartilages in the trachea to complete rings of cartilage in the larger of our bronchi. And then as we get down into our segmental bronchi and into our bronchioles, we start losing muscle and start losing connective tissue, so that by the time we get down to our little bronchioles, we don't have complete rings anymore. And then if you look down here, we have like maybe a couple smooth muscle cells, but not a complete layer of smooth muscle. So you're just getting smaller and smaller and smaller in the structure of the entire wall. Your mucosal cells are also getting smaller and smaller and smaller. So as you start out in your trachea, you still have your pseudostratified ciliated columnar epithelium. And as you move down into your larger bronchi, that's going to transition into ciliated columnar epithelium. And then the columnar epithelium transitions into cuboidal epithelium, and that's going to transition into squamous epithelium. And we don't have cilia on those cells anymore. When we get down to our alveoli, all they are is simple squamous epithelial cells. So what's happening as you move down the bronchial tree is you're losing structure as you get less cartilage, you're losing structure as you have less and less smooth muscle, and you're also losing structure as you get down to just the smallest smallest little epithelial cells we have. But that's okay. You don't want a ton of structure around these alveoli where we're going to do gas exchange. So if we think about our respiratory zone structures, there really are only two structures in the respiratory zone. The respiratory bronchiole and the alveolus, or the alveoli is more than one. And so those, we can actually have gas exchange across here, so that's why we call it the respiratory zone. Okay. And gas in the respiratory zone is being conducted across the respiratory membrane. What's the respiratory membrane? It's a three-part structure across which oxygen and CO2 are exchanged. So the three parts of the respiratory membrane are the simple squamous epithelial layer of the alveolus, the simple squamous epithelial tissue of the capillary, and then the basement membrane that they share. So our respiratory membrane is the site of gas exchange. Or we could say this is the structure across which gases are exchanged. And again, what we have is the simple squamous epithelial tissue of the alveolus. You see, I just abbreviated that, SSE, simple squamous epithelium. We have the simple squamous epithelium of the capillary. And we have the basement membrane that they share. So if we were to zoom into these alveolus, then we would see that we have capillary beds surrounding it. And our deoxygenated blood is going to come in from our pulmonary arteries, and we'll have gas exchange. We'll pick up that oxygenated blood in our venules that lead into the pulmonary veins and bring this oxygenated blood back to the systemic circuit. So that's the respiratory membrane. Okay. How about these alveoli? What about our alveoli? What are they made of? Well, simple squamous epithelial cells called type 1 alveolar cells. So type 1 alveolar cells are the simple squamous epithelial cells that make up the majority of the wall. Well, they make up the wall of the alveolus. So type 1 alveolar cells are the simple, I guess we can just call them squamous. They're squamous. They're the squamous cells that make up the wall of the alveolus. So if we were to zoom in to an alveolus and look at a cross section, we would see that the bulk of the wall is formed by these type 1 alveolar cells. Well, the wall is formed by it. So squamous cells look like eggs when you look down at them. So this is the back of the wall. And so our whole wall is made by these simple squamous epithelial cells. Well, and those are our type 1 alveolar cells. They make up the wall of the alveolus. Then, associated with them, we see this second cell type, great alveolar cells, or this type 2 alveolar cells. And what they do, they're these little guys sitting in here, and they produce this stuff called surfactant. So type 2 alveolar cells, and they secrete that into the alveolus. So our type 2 alveolar cells produce surfactant. And I don't know if you've ever heard that they try and keep a woman pregnant until at least 36 weeks gestation. And that's because at 36 weeks gestation, a baby's lungs start making its own surfactant. So before that, it's hard for a baby to breathe on its own. So that's why you want to make it to 36 weeks, because at 36 weeks, our type 2 alveolar cells begin producing surfactant. And we'll talk more about why that's important in a little bit. Right now, we're just trying to get through the anatomy. Okay, so our lungs. What is their orientation? Well, they are in the thoracic cavity, superior to the diaphragm. In fact, they're sitting on the diaphragm. And so our respiratory diaphragm is that dome-shaped muscle that splits your ventral cavity into the thoracic and abdominal pelvic cavities. So superior to the diaphragm, we have our lungs. And the base of each lung sits on the diaphragm. And then the apex of each lung sits back here behind your clavicle. So this is the apex, this is the base, and the base rests on your respiratory diaphragm. So we'll see that the lungs are not actively involved in respiration. The only active part of breathing is the contraction of the diaphragm, and it's going to create pressure changes that allow for respiration to occur. So we'll look at more about that in just a minute. So, okay, how about our right and left lung? Well, they're sided. I just told you that a moment ago because they have different numbers of lobes and because the heart kind of pokes into the left lung. So if we look into the right lung, it's got 3 lobes. The superior lobe, let me actually draw this out. Whoa! So we've got our superior lobe, and it's divided by this little line called the horizontal fissure. It's not divided. That's what is splitting the superior lobe from the middle lobe. I'm going to do a horrible line right here. This is the middle lobe, and this line is the oblique fissure, because it's at an angle. And so this is our middle lobe. And the middle lobe is separated from the superior lobe by the horizontal fissure. The middle lobe is separated from the inferior lobe by the oblique fissure. That makes this our inferior lobe. And that's our right lung. Our left lung has this little spot called the cardiac notch. And that is where your heart pokes over into your left lung. And your left lung is divided into your superior and inferior lobes, and all of a sudden I'm just getting all kind of silly about my oblique fissure. So I've got superior and inferior lobes on the left side, splitted, that's good English, split from each other by the oblique fissure on that side. If we then look into each lobe, they have differing numbers of segments. So the superior lobe on your right lung has 3 segments, so 3 segmental bronchi. The middle lobe has 2 segments, so 2 segmental bronchi. The inferior lobe has 5 segments, so 5 segmental bronchi. In the left lung we have 4 segments in our superior lobe and 5 segments in the inferior lobe. Again, served by segmental bronchi. Okay, what else about the lung? I guess I could have left it up there. We'll leave our right one up. This, it's got a cardiac notch, so I'm just going to show you a different one. This is our new, same lung. So, if you look at the lungs, they kind of have this indented region here called the hilum or the hilum, depending on who you're talking to, and in it is the root of the lung. So the root comes in, and it's got a main bronchus. So there would be a main bronchus going into the root of the left lung as well. So this would be my right main bronchus going into my right lung. And the root of the lung also contains pulmonary arteries and veins. So my right pulmonary artery is coming into the root of the lung. So I've got my right pulmonary artery. And do you see my pulmonary artery carries deoxygenated blood away from the heart to the lungs. And then I also have my pulmonary veins. So these are my right pulmonary veins, which return my oxygenated blood to the left atrium. So the root of the lung has a main bronchus, a pulmonary artery, and pulmonary veins. So this is my right root that I've drawn here. On the left, I have a corresponding left root that also has my left main bronchus, my left pulmonary artery, and my left pulmonary veins. Okay, if you recall from way back at the first semester, all of the organs in our ventral cavity are surrounded by serous membranes, the double-layered membranes that secrete serous fluid into the potential space between them so that they can reduce friction between organs. The serous membranes of the lungs are called pleura. And so if you look, serous membranes are simple squamous epithelial tissue, and we've got one layer that tightly hugs the wall of the organ. This is the visceral layer. It's on the outside of the wall. Then the visceral layer turns around and gives rise to the parietal layer, which lines the wall of the thorax. So this is the parietal layer. So this is my parietal pleura. This is my visceral pleura. This is my pleural cavity. The space in between is my pleural cavity, and it contains serous fluid or pleural fluid. So what this is going to do is that, like all serous membranes, it reduces friction as the organs move, but this pleural membrane in the lungs actually is going to create this thing that we call intrapleural pressure, and that is what actually allows the lungs to remain inflated. So without that intrapleural pressure, the elasticity of the lungs causes passive recoil. So this intrapleural pressure is what helps to keep the lungs inflated. We'll talk more about that in a little bit.